5 keys to non-operative treatment of adult hip dysplasia. All right, Kevin, why are we even concerned about hip dysplasia? Well, for one, hip dysplasia, not fun to have. It's a major cause of disability, both physically and mentally. Folks have a lot of dysplasia that's symptomatic, can't do the things that they love. It can also be surgically corrected via something called a periacetabular osteotomy procedure, which generally does have good outcomes, although it may have reduced outcomes in folks that have a higher BMI, greater than 25, or they're older than 45 years old, or they have hip osteoarthritis. On top of this, some folks, they don't want to undergo surgery, right? It's expensive, it's time consuming, right? It's not fun whatsoever. And the other piece is that we may potentially have better outcomes with a more conservative approach. So you have a patient that has dysplasia, do you send them to the surgeon right away to go get surgery? Do you try to treat them conservatively? What's going to be the best course of action for these folks? So in today's video, to summarize things, we're going to go first over what does the literature say about non-operative management of hip dysplasia? Does it work? Does it not work? Should we have our patients do it, or should we send them straight to surgery? And then we go over some keys to treatment, and that's going to be activity modification, progressive exercise, cardiovascular fitness, return to sport, and then physician referral. What's up, guys? My name is Dan Pope. This is Kevin Coughlin. We are physical therapists at Champion PT and Performance. Like always, we're going through the literature, picking out the relevant stuff, adding our clinical expertise, and hopefully educating you a little bit. Before we get going, I just want to bring to your attention 2 specific trials that haven't been published yet, unfortunately, right? And one is called Comparing Exercise and Patient Education with Usual Care in the Treatment of Hip Dysplasia, a protocol for a randomized controlled trial with 6-month follow-up. This is called the Move the Hip trial. The second paper is the efficacy of periacetabular osteotomy followed by progressive resistance training compared to progressive resistance training as non-surgical treatment in patients with hip dysplasia, the Preserve Hip trial. And that is also a protocol for a randomized controlled trial. And the problem is that both these papers will give us some answers. So essentially it would say, hey, does doing exercise or physical therapy for hip dysplasia help folks with pain, right? And the other question we want answers to is a PAO as good, better, or worse than just doing physical therapy? And a little bit of spoiler alert, I apologize for this, but this is the research we have. This research hasn't been done yet. But I was kind of hoping when we were doing this podcast that one of these would be published by now, and it's not. So as of right now, we have a giant goose egg in terms of randomized controlled trials for physical therapy for hip dysplasia, and we have a goose egg of studies for comparing PAO with physical therapy. So that's unfortunate, but it's important that you understand this, right? As a physical therapist, I treat this stuff, right? I do exercise, and I think it can be beneficial, right? It's just that we don't have the answers yet to figure out if it's actually effective. So what the heck are we going to do today? We're just going to close out and be like, sorry, we have no answers for you. We're going to try to go through this, and we're going to go over one paper in particular. This is from IGSPT, Non-Operative Rehabilitation Principles for Use in Individuals with Acetabular Dysplasia, a North American-based Delphi study. And I was looking at the authors here, and we are a friend of Keelan and Seki. He's in the sports section of the APTA, the Sports Academy. So it's a good paper. Just to refresh you guys, if you haven't heard about it before, this will be new. This was a Delphi consensus study, right? And what this study said is there's a paucity of research pertaining to non-operative management of individuals with adult dysplasia, acetabular dysplasia. And essentially, we need to come up with some sort of treatment strategy for these folks. So what they did was a Delphi consensus survey where they have a panel of 15 physiotherapists from North America, I believe it was the United States and Canada. And they were experts in non-operative rehab of individuals with acetabular dysplasia by a high-volume hip preservation surgeon. So essentially, the surgeons decided who they sent a lot of their patients to, and they consider those folks experts. And they sent those physical therapists 16 questions regarding evaluation and treatment principles of individuals with dysplasia. And essentially, the questions that had a 75% consensus or greater were accepted. And if it was lower than 75%, then they would discard it. So essentially, we're trying to figure out how we should treat these folks. just by asking experts. So again, not a randomized control trial. We don't know if exercise is helpful. We don't know which exercises are going to be most beneficial. We don't know how long it takes to treat these folks to see an effect, but we're asking experts to see a lot of these and see if we can figure some things out. Hey there. Do you like floppy hip joints? Of course you don't. Guess who else doesn't like floppy hips? Your patients. So that means you're going to have to know how to treat hip dysplasia. And I've got the solution for you. It's an evidence-based cheat sheet for the diagnosis and treatment of hip dysplasia. My promise to you is I'll catch you up to date on the latest evidence on hip dysplasia under 10 minutes. And we go over all the most important information, including definitions and background, prevalence and population, relevant anatomy and risk factors, pathogenesis and clinical presentation, physical examination and radiographic findings, injections, differential diagnosis, treatment, physical therapy, surgery, and lastly, return to sport. So this cheat sheet is 100% free. I will leave a link in the description for you to go ahead and download that. Happy learning. And now back to your video. Anything to add before I get into the specifics here, Kevin?
Yeah, no, that's a good background. And I think that it is unfortunate that we don't have more studies here, but hopefully with that Delphi study, we can learn a little bit. I think hip dysplasia is one of those, fairly elusive, challenging conditions to treat, and trying to figure out if it should be best treated non-operatively or operatively is definitely confusing, and definitely something I'm looking to learn more about and hear you present on here. So should be good, I think.
Yeah, it's funny because when we were discussing the hip dysplasia, like Kevin and I sit down, essentially we sit down at the start of any new joint and we try to plan out the entire pathologies we want to cover, treatments, exercises, so on and so forth. And I was pretty pumped to cover the hip dysplasia stuff. And it's funny because I just wanted to learn more about it. It's one of those pathologies I never learned much about, and wanted to learn more and figure out how I can grow as a clinician. It's just that the rest of the world doesn't care that much probably about hip dysplasia. But I gotta tell you, if you've been practicing for a period of time and you don't know much about hip dysplasia or how to diagnose it, you probably missed this. And the research supports this. It's crazy how long people go with the wrong diagnosis for hip dysplasia. So we direly need more research about this population. And my next thought is that once we learn more about it, we learn how to diagnose it better, I bet you it's going to be way more common than we used to think. And then PTs are going to have to catch up again. Because I remember the same thing went for FAI. When I was in school, FAI was like the new hot thing. And there was like zero studies being done about it. And we were very bad at diagnosing it. And if you look at the stats on FAI surgery, hip labor repair, it's gone up a ton over the past 10 or 15 years. And now it's much more important. There's more research coming out about it. But I think it's literally because we were just missing it and not studying it. And now if we start catching it more, I bet you'll see more research and then clinicians will get better. So I'm just hedging my bets that that's going to happen. But who knows? Maybe it'll flop. It'll die. And then no one will ever diagnose it ever again. We'll see. So step one with treatment. So essentially they sent out questions about how to treat this. And basically I am presenting the consensus agreement points or principles. So the first agreement point that the therapist came to was some sort of activity modification, with the goal being that early on, especially, you want to try to reduce hip joint irritation, right? And essentially all activities that do not increase pain, continue doing them. So anything in your sport, anything in your lifestyle, A-okay to continue, but painful activities should be modified or eliminated. And this is just a short list based on what I've seen for folks who have hip pain, potentially dysplasia in the past. So strength training exercises like squats might be problematic. Single-legged exercise like lunges might be problematic. You might have to swap that out for another single-legged exercise, some other form of lower body strength training that doesn't hurt, right? Activities in sport like cutting, sprinting, pitching, batting. These are all kind of activities that can aggravate a painful hip. We probably have to temporarily eliminate these, just like we would with any other pathology, right? So a lot of like new grads I work with, they'll like do a great job with an examination of a new patient, and they'll be like, oh God, it's a meniscus tear. What do I do, right? Well, pretty much for every single pathology, unless it's a red flag and you have to like refer out for something, we're trying to unload things. We're trying to strength train it and progressively work back to whatever goals the patient has. So in my mind, this is step one. We're activity modifying just like we would with any other type of pathology. And number two, therapeutic exercise. Now this one, is a huge can of worms because we have no idea what's going to be most beneficial from an exercise standpoint for these folks. But there was some agreement among the physical therapists. So, one, therapists agreed upon starting by strengthening local muscles and then working towards global muscles or global movements over the course of time. An example I gave is that maybe you start off by strengthening posterior lateral hip with things like clamshells. And over the course of time, we progress to a single-legged squat. So kind of same principles that we would use from a progressive exercise standpoint in any given pathology. There was also some agreement about starting with isometric, working towards concentric, and eventually going towards eccentric. And this is especially useful when someone's particularly painful. My own personal thought, and I don't know if this is right, I'd probably start them off with the hardest thing they can tolerate well. So I wouldn't take them all the way back to isometric. I think that when folks see a guideline like this, when they have a patient that comes in that's fairly high level that has some dysplasia, they're going to think, okay, we have to go straight to isometric. You might not have to. That might be way too easy for that patient. But I do think it's important that we start easy and work our way to harder over the course of time. There was some agreement among lumbopelvic and neuromuscular control exercises with a focus on single-legged control. So the exercise examples I think would be relevant from this standpoint will be things like hip hikes and airplanes. So if you think about why folks end up with hip labral pathology associated with dysplasia, because we should have probably explained this earlier, but we have prior episodes that explain this, is that if you're having dysplasia, it's usually not the dysplasia that hurts, right? The dysplasia is under coverage of the socket over the ball. What ends up eventually hurting is some of the damage that occurs because of lack of stability. And usually this is labral pathology, right? And the thing that's typically aggravate the labrum, particularly if a cam morphology is involved, is excessive, hip flexion and rotation. So if I'm not able to control hip flexion and rotation and adduction, then I may end up with hip labral pathology. So one of our goals from a neuromuscular control standpoint, and I almost hate this word neuromuscular control, because what the hell does this word even mean? I feel like people use it for any sort of exercise, is we're trying to be able to control these movements that could potentially cause more damage or injury when the patient is doing their activity or their sport, which is probably going to be hip adduction, hip internal rotation, hip flexion, right? So movements like single-legged squats, single-legged deadlifts, exercises like standing hip hikes, exercises like airplanes are probably going to be very valuable because we're working on controlling those at-risk positions, right? Some other neuromuscular control ideas are keeping the pelvis or the hips level during exercises like step-ups. So if I'm getting excessive hip drop or internal rotation, dynamic valgus while I'm doing my activities, that might be increasing too much load to those at-risk structures like the labrum, right? Second piece is starting with low demand exercises and working towards high demand exercises. And this could mean you start working in supine, graduate to quadruped, and then eventually you're doing standing exercises like a pelvic tilt, or maybe you're doing some sort of hip adduction exercise like a hip drop, starting quadruped, working your way to single-legged stance, right? The last one is double leg exercises to single-legged exercise over the course of time. This makes a lot of sense. If you have two legs on the ground, you don't have to control as much valgus, frontal plane motion, transverse plane motion. As soon as you go into single leg, you do. It also kicks on the glute medius a lot more. So they just recommend starting in double leg and progressing to single leg over the course of time. Any thoughts on these things, Kevin?
Yeah, I think that's all good stuff. And I took a few notes there, but I think the first thing that you said that I thought was really good is that this, as well as most other things we treat, is a combination of what we add in rehab and what we subtract or modify in rehab. And I think a lot of times patients get a little worried where you're removing things, you're taking things out that they love doing. But I think if you just educate them that, look, PT is a combination of taking some things away, letting things calm down, and then adding things back in. And we'll definitely get back to the things you want to do. But for a period of time, we might need to remove those things to let things calm down. I think is a helpful approach. They can kind of see the rationale of why we're removing certain things. Like maybe they're a weightlifter, they love snatching, cleaning, squatting, and we're going to have to modify those things for the time being because the hip's super irritated. But we have a plan to get you back to those things. So I think that's important. You mentioned kind of starting local and then going global with the strengthening exercises. And, something I know our boss, Mike, says all the time is that a weak muscle can't stabilize. So when you're looking at something like dysplasia and you're trying to create stability in the hip, it's probably important to strengthen those local muscles first, and then go on and progress to kinetic chain exercises or getting back to the compound lifts and things like that that the patient wants to get back to. And then something I think that you've always done a great job with that I've tried to learn from and adopt in my own practice is being okay leaving in hard exercises. Like when someone comes in, I think a lot of times, like you said, we see the protocols and maybe we start with isometrics or we start with some very low level activity. Well, I think a lot of times you can really still continue doing some very hard things. You just want to find what's the hardest thing the patient can do. And I think that creates a lot better buy-in. Like I know if say I came to you for hip pain or knee pain and I'm a runner and I want to continue running, maybe I'm running 6 days a week, but maybe you let me keep running 4 days a week and you have me do a little bit of cross training on the other days. And I'm going to be way happier than if you tell me that let's cut out all 6 days of running and have you just do some cycling and easy walking. So, and sometimes you get it wrong. Sometimes you say, let's try with this approach and see how you tolerate it. And maybe their hip pain doesn't get any better. And that's okay. Then maybe, all right, let's cut out more days of running. But I would appreciate as a patient letting me try to continue doing what I want to do. And then let's just take away as little as possible. And I think I'm more likely to buy in and want to follow your rehab plan because you're taking my goals into consideration. So I thought that was good stuff.
Yeah, it's kind of like the fitness pain-free mantra, right? Keep people
Mm-hmm.
exercising as much as possible. And I think that really helps from a psychological perspective because a lot of the patients we see, it's not the same for every single outpatient setting. I get this, right? I've been in those settings. Most folks don't exercise at all. Most of the folks that come to see us, they're either an athlete or they're an adult who just really likes fitness. And their goal is to get back to fitness. And their pain is keeping them from being able to do that. So as much as we can align with those goals and continue doing things that don't aggravate that area, I think we help. And I think the other part is that people get deconditioned. So if you have a patient and you're not able to load them for a period of time, they decondition. And now you have a harder mountain to climb back up again, get back to your activities, and your risk of injury goes back down too. So it's not just a matter of personal preference. I think the risk of re-injury is probably going to be a little bit higher if you dose down too much in the beginning stages of rehab, right? The other thing I will say is because I just don't want to overstate the whole hip flexion, internal rotation, adduction thing. And I recently did some learning about micro instability, which some of this is going to be lumped together in a master course for hip dysplasia, is that when folks have hip dysplasia, they have undercoverage of the ball and socket joint, right? So you usually have excessive motion. Sometimes this is coupled with micro instability, meaning they have too much motion coming from the ligaments surrounding the ball and socket joint. So they have hip laxity. And those two together can cause problems. And a lot of athletes, ballet, gymnastics, we probably need to get Dave Tilley on the podcast at some point. They deal with more problems with end range hip extension, abduction, external rotation. So think about a split. If you're jumping and kicking into a split, it's a lot of strain on the anterior portion of the hip joint. That can cause instability and problems over the course of time. So going back to my earlier point is that in the beginning stages of rehab, we have to stay away from those provocative positions. That depends entirely on the patient and what kind of aggravates them. So the patient that's a gymnast, they may not tolerate end range hip extension rotation, right? And we might have to guard that early on, but they may actually handle a lot of hip adduction, flexion, rotation, right? So I think a lot of it is being smart about the subjective, being smart about your evaluation, figuring out what feels good and what doesn't, push the things that feel good early on. Don't expect certain positions always to feel bad. I go in with preconceived notions all the time. When someone tells me they have like C sign, I'm like, oh yeah, it's going to hurt when you squat. It's going to hurt when I do a fade here, right? But sometimes you're wrong. So make sure you do your due diligence and your exercise program can mimic your evaluation. Sorry, that was a lot. That was a lot of stuff. Didn't mean to be that long.
No, that's great. Good.
Okay, let's move on. Therapeutic exercise. This was also a very interesting one to me and something that early on I found in my hip patients, and it wasn't just dysplasia, but also FAI. Hip flexor, something wonky is going on there, right? So in patients that have hip dysplasia and patients that have hip labral pathology, FAI, resisted hip flexion hurts. And sometimes stretching to hip extension hurts too. So what the heck is going on there? So when we do any sort of end range hip extension, it's driving the ball anteriorly in the socket. If there is some sort of hip labral pathology, most of it is anterior superior. We might be aggravating it. If I do resisted hip flexion, it could be pulling the ball anteriorly in the socket. If you think about the hip flexors, attached in the front of the femur, pulls that ball forward into the aggravated labrum, right? So what happens in these patients is it just kind of hurts to do hip flexor training, right? Kind of a weird phenomenon. So you basically have to be pretty careful with hip flexor training because it can really aggravate the joint. And the clinicians in this study were all in agreement here. And they recommended only starting hip flexor training once the patient achieves greater posterior lateral hip strength and a reduction in joint irritability, right? So I just recommend using very easy hip flexor exercise and progressing over the course of time. We have a ton of videos on hip flexor exercise and how to dose it. So search those out if you want some ideas. They recommended starting with a short lever hip flexion and progressing to long lever. Think about like a straight leg raise, doing it at first with your knee bent and then progressing towards a straight leg over the course of time. And essentially the idea is that the posterior lateral hip joint controls this anterior strain. So if I start doing a lot of hip flexor exercise early on, in the absence of strengthening the posterior lateral hip, I may cause more issues over the course of time, right? And the other thing they said in the Delphi consensus study, which I don't know that I particularly agree with, is that they recommend only strengthening the hip flexors if the patient needs it for their sport, right? Although one dissenting panelist thought all patients should train hip flexors if not provocative. Here's my personal thought. We know this from the FAI literature, and we know this from hip dysplasia literature. People get weak in their hip flexors when they have these pathologies, right? And my personal thought is, why would you not try to strengthen this? We know that the hip flexors are a very important muscle to control the front portion of the joint. And I think that everyone should probably do it. I don't see a reason why we shouldn't. I mean, if you have a patient that has, let's say, micro instability and they have dysplasia, they're having trouble going into hip extension, let's say for splits or jumping in splits, right? I'm not a gymnast, so I apologize. There's probably words for that, but I'm just not using them appropriately. Your hip flexors control that motion. If you don't establish strength control from those muscles, how are you going to get your patient back safely? So what I will say is that I'm disagreeing with the 15 biggest experts in North America, Canada and the United States. So take that with a grain of salt, but that was my probably only point of disagreement. And I always feel like folks should be trying to train their hip flexors when they have these pathologies, right? This is my personal thought. Anything to add to that or any agreement, disagreement, Kevin?
Yeah, I think I'm with you on that. I've heard you talk about that for a while. I think, like you alluded to with FAI, we know the hip flexors are undertrained. It's almost like in FAI early on, maybe we're reducing activities that demand hip flexion, but then that's probably something we should get back to because it's something the patient avoided for so long because of pain. And I agree. I just don't see why a normal muscle group is something we would avoid training. I don't know about with this expert panel, but I think a lot of times patients don't think of it or clinicians don't think of it because there's that older narrative kind of that like lower cross syndrome. And you think hip flexors are tight because people sit a lot. And because of that, it's a muscle group that we should stretch more than strengthen. Although I do think for some pathologies, there is utility to stretching and trying to lengthen the hip flexor. I don't know if that narrative makes much sense. And we know with strengthening, if we're doing eccentric exercises like rear foot elevated split squat, where the hip flexors are getting a pretty good eccentric stretch on the back leg, we're probably lengthening that muscle as well. We're adding sarcomeres, we're adding to the lengths of like the muscle fascicle, probably something worth doing. So if your goal is mobility, it makes sense to strengthen the hip flexor. And if your goal is strength, it makes sense to strengthen the hip flexor as well. And obviously there's a way to do it where you're not pushing through the patient's pain, but you're just getting the hip flexor stronger. So I'm totally with you. I think that's something that is often overlooked, and I'm not exactly sure why.
Yeah, and I just want to say overall, these are really good recommendations. I think as human beings, we're just really good at pointing out the things we disagree with.
Hmm.
Overall, great recommendation. You can totally screw someone's hip up if you do too much hip flexion early on. My only counter argument is that what sports exist that hip flexion is not important, right? Any field sport where you're running, the hip flexors are working a lot, and that makes
Hmm.
up the large majority of what we treat. And then a particular population that gets this frequently is going to be dancers, ballet, so on and so forth, where hip extension is even more important. So I would just, give a little pushback and say, like, yes, this is accurate. I think you probably need to focus on it more with specific sports that need it. But I would also challenge you to find a sport that doesn't need a whole lot of hip flexion, right?
Hmm.
Some sort of strength into hip extension where the hip flexors are working a lot and are important. Hey, pardon the interruption, but if you're liking this content, I think I have something else that you're going to love. It's a free mini course where we go over solving some of the biggest problems that physical therapists are facing today. So, what are these problems? Number one, failing reimbursement. Medicare reimbursement has dropped 10% over the past 10 years, despite inflation going up 32% in the same time period. Documentation and admin overload. Physical therapists are often spending significant time doing notes and communicating with insurance companies, and this is often unpaid. High productivity quotas. Failing reimbursement rates force physical therapists to see more and more patients. Burnout and poor work-life balance. High productivity demands and extra work drive burnout. Insurance-driven restrictions. Insurance companies often cut patients off before they're ready, like ACL reconstruction patients, or they won't cover insurance for certain populations. Let's say a very athletic individual. They don't care about your athlete getting back to Olympic weightlifting. Debt versus pay and balance. The average student debt after graduation is $153,000, and our salaries are not matching this amount of debt. Lack of public awareness and referral dependence. Patients don't always choose PT first. They don't know our strengths as physical therapists, and they oftentimes will favor other healthcare providers. So how the heck do we solve this? We do this through a 6C process to help you start working towards that career of your dreams. And before we go into that, we got to figure out first, what do physical therapists want? So we want to be incredible clinicians. We want to be respected and valued. We often want to work with a specific population in a specific setting. We want to be able to practice the way we want to be able to practice. And generally, we want higher incomes. Now, given the current state of physical therapy, it makes a lot of sense that folks like you and I are upset. So in this mini course, we go over the 6C framework to get off the hamster wheel. It starts with clarity. What is the ideal patient that you want to work with? Next is connection. How do we become part of their community? Next is captivation. How can you help them with their specific problems? Next is competence. You have to learn how to treat these patients inside and out. Next is building confidence. That comes with time and reps, because perfect practice makes you perfect. And lastly, compensation. You want to get paid what you deserve. And this mini course will start you on your journey there. I help you to transform your career, start doing more of what you love and less of what you hate. This mini course is 100% free. And better yet, if you finish the course and then finish the quiz afterwards, which is nice and short, you can get 3.2 CEUs for physical therapists, physical therapy assistants, and athletic trainers. Again, it's 100% free. I'll leave a link in the description. Go ahead and click on that and download it, and I'll see you inside of the mini course. Now, back to your program. All right, stretching. Should we stretch with these guys? So, first thing I will say is a hip dysplasia is a disorder characterized by instability coming from a bony aspect. So, literally not having enough coverage of the socket over the ball, right? So, the experts were in agreement that it should not be a focus of the rehab programs for most of these patients, and only include it if a patient has a specific limitation, right? So what I will say is that I just finished up making the protocols for hip dysplasia, right? As well as hip FAI. They're inside of Fitness Pain Free Insiders Academy if you guys want to check those out. But I had to make the decision of whether or not I want to include any sort of stretching into the program for these athletes. And one of the things that I think about sometime, and can kind of Greg Lehman is kind of the guy that got me thinking about this a little bit, is that when you stretch a muscle, right, you're putting a low level of strain on some of those passive structures. And I think we probably want a degree of that, right? And at least in my mind, a light dynamic stretch, potentially a weighted stretch, is a way to start exposing that joint to the end ranges they need to control, right? And if I think about someone that has shoulder instability and I want to return them back to sport and they're going to be exposed to that end range, I strengthen the hell out of that. And one of the easiest ways to get into the end range initially is just a light stretch, right? So I definitely agree. Are we doing a ton of static stretching for these folks? Definitely not, right? But do I think that some light dynamic stretching, some weighted stretching, right, and strengthening through those end ranges eventually is important? I would say definitely yes, right? What I will say as a personal anecdote as well is we probably have to be cautious with internal rotation and flexion, particularly if those folks have cam morphology, because that's going to put strain on the labrum, some compressive forces on the labrum that potentially are problematic early on. So I used to see a lot of this in social media. I don't anymore. Is that folks have hip labral pathology, you stretch them into flexion and internal rotation. If you're trying to flare someone's hip up that has FAI, that's a great way to do it, right? So I don't recommend that early on, but eventually we probably need to build into those ranges as symptoms kind of die down, and some light kind of passive and then dynamic active stretching, eventually weighted stretching is probably a good way to do that, right? Any thoughts there, Kevin? I really had to think a lot for this one.
Yeah, I think that's good. And then I think, you had referred to our coworker, Dave. And I know with gymnasts and that population, some of those folks who are very hypermobile, he'll caution against that half kneeling hip flexor stretch where you're really shifting your body forward and getting like pretty aggressive extension stretch on the back leg. Like you said, it's a pathology characterized by instability. So I think what I've heard Dave describe is sometimes there's like a fulcruming of the femur on the anterior capsule of the hip joint. And for certain people, if the technique isn't right with the stretch, they're probably making their instability a little bit worse, or potentially could be. So I think, like you said, a light dynamic stretch, when indicated, is probably okay. And like you said, thinking about what Greg Lehman was talking about, it is some strain to the joint, some strain to the capsule, and a little of that is probably needed to adapt. So I think that it makes sense to do some stretching. As always, I think it's just good to educate the patient on. Feel like a lot of these patients tend to feel tight. And I think they tend to feel tight because they're trying to create stability with their muscles for a joint that is maybe compromised in its ability to stabilize. So explaining to them that long-term strengthening is probably going to be the most helpful thing, but a little stretching, I think, with proper guidance and good technique is probably okay. And in some cases, probably a good thing to do.
Yeah, I remember this like 10 years ago, but when I first kind of met Tilly and was first hanging out with him, like he essentially showed me that study where they had x-rays of gymnast hips, and your hip has to sublux to get to that position, right? So like essentially folks have to have hypermobility at the hip in order to even do these movements, which was wild to me, right?
Amazing.
So the second thing that I think about sometimes too is that we've kind of like demonized a lot of stretching. I think a lot of it is that we work at Champion, we work with a ton of baseball players. There's a lot of anterior laxity, but that's also in the throwing shoulder, right? It's not necessarily at the hip. So we don't stretch those folks so much. And I think that's probably relatively good advice. But the other thought too is that if you're trying to put a little bit of strain onto ligaments, then doing some sort of passive stretch might be one of the best ways to do it. Because if you're doing some sort of weighted stretching, and this is just a theory, I don't know, it hasn't been tested, but you're actively contracting, you're protecting the ligaments with your musculature. If you're doing a passive stretch, you're trying to relax the muscles as much as possible, you may actually be putting a strain onto the connective tissue. And the other thing I will say, and like we talked about this 10, 15 years ago, is that when you stretch someone, right, you're not really making a change in that tissue unless you do like a low load, long duration stretch or weighted stretch or something very ballistic, like throwing a baseball. So like when people have anterior instability from throwing a baseball, we're like, oh, don't stretch the shoulder. But in reality, the amount of strain on that capsule is probably low, right? I'm not saying to go stretch in front of your shoulder. We don't, right? So I wouldn't take this out of context. But I don't know that we're actually going to make a true change in the capsule. We know stretching is mostly neurophysiologic adaptations. Are we actually loosening up that capsule by stretching? I would say probably not, unless you're going very aggressively with it. So basically a long, I don't know, sidetrack. Sorry for that. But at least that's kind of what I've been thinking about more recently, because this is kind of dogma. And I think that it's probably not entirely accurate. Although I will also say it's probably good not to do a ton of stretching for these folks, especially early on, because if nothing else, it might just aggravate them a lot, right? We want to stay away things that kind of aggravate the area, and over the course of time, you progress more. At least for my shoulder, I've dislocated posteriorly. And I think one of the absolute best things that I've done to reduce recurrences is to train end range a lot and heavy, right? And I think that's developed a lot of strength and stability for my shoulder in particular. So I would also think for folks who have hip issues, then that might be something that's worthwhile long-term in their advanced rehab. All right. Next one is cardiovascular fitness. This one actually surprised me a little bit, because I feel like as physical therapists, you don't see a lot of cardiovascular fitness going on unless it's hopping on the bike for 10 minutes to warm up before a physical therapy session, right? That's kind of like the classic PT session. Get on that bike, right? Hop on the new step. Maybe it's upper body erg. Get warmed up before we start our physical therapy. But anyway, 15 out of 15 physical therapists polled were in agreement. We should have a focus on cardiovascular fitness in these patients. And that should first consist of low impact activities introduced when pain-free, starting with things like cycling and swimming, and working our way up to things like running over the course of time. What I will say is a lot of folks that have hip pain, hip dysplasia, cycling sometimes feels bad because you're going up into hip flexion. So it might not feel good. I've had a lot of patients that actually feel better with things like running and elliptical than they do with cycling. So that's just something to think about with your patients. A lot of folks are going to feel fine with cycling, but they may not, right? Swimming, kind of same deal. Feels good in some folks, not in others. It's low impact, but think about what you're doing with your hip flexor when you're swimming, right? It's very active. You're kicking the entire time at end range. So if you have someone with that anterior instability and they're going to end range hip extension and firing the hip flexors, that might be provocative, right? So just think about the individual athlete that's in front of you and then let them know, I think these are good activities, but we're gonna have to try it first and see how it goes. If it's pain-free, feels great, keep pushing it. Doesn't feel good, then don't do it, right? I think the idea is that there's less impact with cycling and swimming, but personal anecdote, I've seen cycling and swimming be worse than running for a lot of folks. I think it's just like, there's still that whole idea that running is like vilified because there's that impact. You know what I mean? And I do think that in a lot of cases, you might have to back off. I can think of a few patients with hip dysplasia. They just didn't tolerate running whatsoever. And there are other things that were better. But what I will also say is that sometimes running feels better than the others. All right. High impact activities are considered things like running and agility, and they can be incorporated once strength improves and irritability decreases, which makes total sense. What are your thoughts on this, Kevin?
Yeah, I think, like you said, there's a lot of variation person to person, where sometimes certain things, it's not always high impact exercises feel worse. Sometimes you're not in as much hip flexion if you're jogging, you're running at an easy pace. We know that's probably more below the knee muscles working, so a lot of calf and foot and ankle might be better for that person with hip pain. So I think it could be worth trying different modalities and seeing what the patient enjoys the most and what they want to do. But you could totally see, like, certain types of cycling, you're in a ton of hip flexion. And then against kicking in water, you are kicking against a little bit of resistance. So, I think promoting cardiovascular exercise is something that we try to do. And as a profession, we should definitely keep doing. It helps with so many things, whether it's directly related to the pain problem, like with back pain and neck pain. It seems like it helps reduce pain a ton. And then we know it improves all other types of health markers. So finding some form of cardio that patients can do while rehabbing, I think, is super important. And maybe just have them try different things and see what's driving the best and how they feel while performing it. So I think any of those modalities is probably okay for certain people at certain times.
Yeah, and we haven't studied this at all in patients with dysplasia, but I will try out gait retraining, right? Let's try to increase that cadence. Let's see if we can get rid of hills, because we know those things will increase stress on the hip. And sometimes when you dial that back, change the programming, they can actually run quite comfortably. And at that point, you probably don't need to pull it out completely. So A, has been studied. B, definitely give it a shot. See if it helps your patients. Just some things to consider. All right, number 4, return to sport. How do we get these guys back to activity? So the first part of return to sport really depends on the type of sport, would be running. So when you initiate running, essentially the expert agreed upon running should be started when pain-free or minimally irritable. What I would add, and this is coming from Chris Johnson, who's a great running PT, is you want to make sure their gait doesn't look terrible. If they're running with a limp and it doesn't hurt or it's minimally irritable, I don't know that I would keep running. I'd probably try to make sure they can run in a way that's pain-free, minimally irritable, and they don't have a limp on top of that, right? And essentially, the experts also agreed on that running should start after normal gait with a solid speed. So if you can walk quickly for a period of time, that's also a good sign you may be ready for running. The second piece they agreed upon was having good single-legged control. Basically, can you control your pelvis well in a pain-free way when you're doing something like a single-legged squat, right? My last personal thought there was that we probably should be looking at strength symmetry. That's one of the big things that we use as a criteria-based progression. If someone has garbage strength of the posterior and lateral portion of their hip, I probably don't want to do a lot of running, especially high-speed running. So I would say as a criteria, maybe you want to see 70, 80% symmetry before you think about running as well. But that's not something they talked about in this paper. Any thoughts on that, Kevin?
Yeah, I think the strength symmetry is good. I think we think about that to clear people for running with different things like post-op ACLs or post-op meniscus repairs in the knee. Should probably consider that with most pathologies. Like if we're saying with ACL, we'll start running when you're about 70% as strong as the uninvolved side, then we should probably look for something fairly similar with hips as well. And then I think the other thing you mentioned is they should have good tolerance to walking. Maybe they're tolerating a walking program for a few weeks before starting running. I'd also probably want to see some tolerance to a little bit of impact. So maybe they're doing some low level kind of extensive plyometrics without much pushback. They're doing pretty well with that. And then I think if we consider all those things, then it's probably good to start, or definitely could start a running program. I think what you mentioned previously about gait retraining or increasing cadence, that makes a lot of sense to me, right? If it is hip extension that sometimes is bothering people with hip dysplasia, then when they're, if they have a longer stride length, they're in more hip extension in the back leg before going into swing phase. And an increasing cadence seems to, shorten your stride length a little bit and might make that more comfortable. So I think kind of doing those things, looking at strength, tolerating a walking program, tolerating low level, extensive plyos, and then getting into running, see how their technique looks, how their form looks, and maybe playing around with their cadence should be able to cover your bases to have them do some running pain-free. And then maybe you start with like a walk run interval and just build up gradually to make sure that each week they're building on the previous week, and you're looking at symptoms and making sure they're kind of heading in the right direction.
Hey there, you little learner. Do you like this content and want to go a little deeper with that learning? You should join us with our online community, Insiders Academy. It's our premium subscription membership to help you become a better coach and clinician. We do a lot of good stuff at Insiders. We fill in those gaps in knowledge that school didn't teach you. We go over things like exercise technique and prescription, programming, periodization, strength conditioning principles, and advanced rehab. Let's get you proficient there. We also help to keep you up to date on the latest medical literature, even if you don't have time. And we do this with cheat sheets. And these are PDF downloads that catch you up to date on a given topic in under 10 minutes. And we've got a lot of them, over 50, and we're constantly updating them and adding new ones. It's pretty much the exact same thing as downloading all of our knowledge directly into your own brain. We also keep you up to date with our master courses. We cover pathologies in depth so you know exactly how to diagnose and treat patients with these issues. And we're really thorough, going over prevalence and prognosis, risk factors, anatomy, history, clinical presentation, diagnosis, differential diagnosis, patient education, and exercise prescription, as well as manual therapies. We have a whole bunch of master courses, and we're always updating and adding new ones. Some of the big dogs are rotator cuff related pain, knee osteoarthritis, shoulder instability, femoral acetabular impingement syndrome, SLAP pathology, cervical radiculopathy, lateral ankle sprains, and radicular low back pain. Who doesn't love some searing back pain going down their leg? We also include case studies with every one of our courses. This way, you can see exactly how we diagnose and treat. Each master course comes with in-depth protocols, both non-op and post-op. This way, you know the exact exercise we'd like to use with videos of all movements, how many sets, how many reps, how do the exercises progress over the course of time, what are the relevant manual therapies when they're indicated, and exactly what you should educate your patient about. Hey, are you a physical therapist, athletic trainer, or physical therapy assistant and looking for some CEUs? Well, we got you covered, and you can even earn CEUs for watching the content you're watching right now. Finish up the master course, take the exam, get the CEUs. Easy peasy. With Insiders Academy, you also have community access. Basically, you can have all of your questions answered by me and the rest of our team at Fitness Pain Free. This way, as you go through the learning and you have a question, you'll get it answered. Best of all, you get started with Insiders Academy for just $1 for a week-long trial. After that, it's $25 per month. If you want to save 2 months, get them for free, then sign up for the yearly membership. I'm going to leave that link with a discount in the description below so you can check it out, and I'll see you there. Now, back to your learning.
All right, next thing was to talk about is plyometrics or some sort of jumping. So the way the authors recommended this, and we kind of think in reverse here at Champion, we'll talk about this in a minute, is that plyometrics should begin when there's minimal to no pain with running and agility, when there's appropriate pelvic and lower extremity neuromuscular control. So essentially, if people can do something like a single-legged squat with minimal hip drop and minimal transverse plane motion. So if you do a single-legged squat and they can't control motion at all at the hip, maybe they're not ready to jump, right? One of my personal thoughts is that a single-legged squat through a partial range looks a lot like a single-legged landing. So if they can control a single-legged squat well, they're probably not going to be able to control a single-legged landing, right? Here's a personal thought, and maybe it's just a difference of opinions. And if I'm imagining if we talk to these experts, they probably agree with us as well. But we actually do a lot of low-level plyos before we start running, just because running actually has more strain on the hip than certain plyometrics. So what we typically do is we introduce things like pogo jumps and walking prior to a return to run program. And usually, like Kevin said, we'll introduce a run-walk program, so we're not going straight into running, right? What I'll also say is that some plyometrics are probably going to be provocative and some are not. So if you think about a pogo jump with 2 feet, there's not nearly as much strain on the hip as a single-legged pogo jump, right? And a pogo jump by itself is a lot of strain that goes through the foot and ankle, not as much through the hip. So essentially, if you have someone that has hip dysplasia, pogo jumps may feel absolutely fine. And you might actually be able to get away with some double-legged pogo jumps that are medium to high height and still maintain some of that plyometric ability, right? Because that's the whole fitness pain-free mantra we talked about. Let's keep people doing as much as they can that doesn't aggravate the area, right? And then eventually, let's say single-legged plyos, particularly single-legged plyos where you're loading up into more hip and knee flexion, we probably have to be a little bit more careful for those, right? So what I will say is that as physical therapists, we love this like phased rehab approach of this before that. And I think in a lot of places that is really important. But at least for me and my way of thinking, I might be doing that before this, if that feels better than this, right? It's your job as a physical therapist, particularly for non-op patients, to meet them where they are in terms of irritability and try to push as much as they can so they don't get deconditioned and they still feel like an athlete, right? Any thoughts on this here, Kevin?
Yeah, no, I totally agree with that. Kind of what I was saying on that previous slide is I think that we'll see certain things in guidelines, and maybe if we had a conversation with the people who made them, like you said, they'd probably agree with us on the whole. Plyometrics are such a broad term that some are very aggressive and probably put a lot more strain on your hip. I think like a maximal effort bounding would probably be pretty challenging. But like you said, a double leg pogo jump is very low level stress in the hip. And it's probably preparing the tissues for running, like your calf complex, in a way that leads into running nicely. So I think you think about the stresses of the demand of running and what plyos will prepare you well for that aren't so aggressive on the hip. And like you said, that's kind of what we're looking for is to meet the patient where they're at. And it's not always this before that. Sometimes we can add something that appears to be coming later sooner, but we're doing it in a different kind of safer way that is more specific to the task we're about to start. So I think that's an important concept to think about.
Yeah, I think this is like the messy middle that a lot of clinicians have a hard time with. It's like they don't know when to introduce things, when it's okay to introduce things, right? And
I just, this is what I love. I guess it's like, again, this is what we do at Fitness Pain Free. When someone comes through the door, I love that I can often tell them, oh, it's fine to do that. Oh, you don't need to stop squatting. You can keep deadlifting. Oh, actually, this is fine to do. People love to hear that. So I think there's a ton of fruit in that. I just think that clinicians often have a hard time doing it. It is experimental. I think you often do run the risk of flaring someone up a little bit more so when you do these things. But if you're not taking them to the gym, try some stuff, try to run, try squatting, try single-legged exercises, see what feels. These are principles. They're not kind of all to hold true for patients. There's been times where I'm like, oh man, this movement's definitely going to hurt this patient. And I try it and I'm like, seems absolutely fine. I don't know why, but I'm going to keep it in the mix, right? And essentially, I like to use the pain monitoring model. Let's keep it 4 out of 10 or below. It feels back to baseline the next day. There's no weird like limp or compensation. Then let's go with it, right? We can always change it over the course of time. But, early on, we try to add a little bit more so, when it's, tolerated well. So when can we return to sport? We talked about returning to a little bit of running, a little bit of agility, right? When can we get back to sport? So the experts agreed that when patients can demonstrate adequate pelvic and lower extremity neuromuscular control doing all single-legged tasks, right? They didn't really mention what those tasks were, but I would say probably hop tests, right? Can you control the hip well when you're doing single-legged jumping and landing? And what does control mean? Well, are you sinking into a ton of hip drop? Are you sinking into dynamic valgus? Are you rotating when you're landing so that your leg is falling behind you, right? Are you leaning way over to the side like an abduction lurch to land because you don't have the control in your hip muscles, right? Essentially, we're seeing if athletes can land well. And the last thing they mentioned is that we should probably consider psychological readiness testing. There's a whole bunch of surveys and outcome measures out there you can check into. But I agree with those things. Any thoughts there, Kevin?
Yeah, I think that all makes sense. Like you got to look at, can they perform the demands of their sport? Like you said, well, without a ton of pain, without compensation. And maybe that's something, if you're lucky enough to have access to force plates, you could look at some metrics on that. If not, you could look at kind of maybe some similar ones that we use for return to sport after ACL, like hop testing, different types of jump testing. Maybe you're getting also like a qualitative look with video recording, a little easier to see, like you said, if there's a hip drop or some type of like rotational compensation or that dynamic knee valgus type compensation. You're looking at, can they tolerate all these things similar to the other side or the uninvolved side, maybe similar to population norms if those are available for anything. And then maybe they're starting to do some slowly integrating participation in their practices. They're tolerating that well. I think, with these types of pathologies that just don't have as much research as some of the huge ones with return to sport like ACL, we can use a lot of those concepts that we utilize for ACL return to sport and think about how we can apply them to something like the hip. So I think the things you were talking about make a lot of sense and things to include in that final stage of rehab.
All right. Some additional things about return to sport. Athletes should be tolerating all sport-specific tasks, including all running and plyometrics. And if you are listening to this, I apologize, but if you're watching this, I recommend watching this at some point. You can see some of the abnormal mechanics here. This is Dave Tilley doing some jumping and landing over here. And essentially, abnormal mechanics would be having excessive dynamic valgus. I think when we think of dynamic valgus, we think about what's going on the knee. But when we're having dynamic valgus, you're also getting some hip internal rotation, right? And adduction, the legs coming across the body, which can increase some of the strain on the hip, right? The other issue you may see is a hip hike. So when folks don't have the strength and control they need within the hip to land well, sometimes they just lean to the side. So when we land, we don't have to control those forces of hip drop, the hip hike instead. And some folks will see that they do an excessive amount of hip dropping. They can't control that fast drop of the hip well. They may go excessively into hip adduction, and that can also aggravate the hip. So you see these jump tests in ACL literature for the most part. I think they're probably relevant at the hip, and we just want to make sure that we're not seeing these types of compensations prior to return to sport. Again, these tests are not validated whatsoever with hip dysplasia. So in 5 years, I may be eating my words 100%, but it does make sense. And we're just drawing this information from other
pathologies that we've already studied, right? A few other personal thoughts from a return to sport perspective. We probably want to see 90% plus strength, all directions of the hip. I'm kind of curious why they didn't include any sort of handheld dynamometry, because they did talk about how hip dysplasia folks have less strength, but they didn't say you need to restore that strength to return back to sport. Usually that's step one. When we're looking at return to sport, we're looking at range of motion and strength. Is your strength back? Is your range of motion back? And is there pain and range, right? That's usually step one. So I feel like they didn't talk about that much. Again, like basically the answers that clinicians gave were based on the surveys that they received. So if they were questioned about strength, they probably, I assume, would say it's probably important, right? And on top of that, probably doing some hop testing. We already talked about this. Triple jump, maybe triple crossover, drop vertical jump. We use force plates at Champion. We're very lucky. We can do counter movement jumps, single leg counter movement jumps, and hop tests. We can basically look at all forms of plyometrics. We also have a 1080, which is amazing too, because we can check kind of like lateral explosiveness. We can look at horizontal force production with acceleration. We can look at all sorts of goodies that the average clinician can't, right? So if you don't have a 1080 sprint and force plates, that stinks. I'm sorry. And just use a hop test as best you can. But I do feel like those are really helpful when you have access to them. Any thoughts, Kevin?
Yeah, I thought that was pretty cool because I hadn't seen your slides at all, but we kind of said the same things, that's what we look at for return to sport. So I think that everything you just said is exactly what I would try to do for hip instability, but for most things, like for most return to sports, that's the algorithm we're going through. We're making sure they have good strength, good range of motion, good strength, maybe being at least 90% the other side or more. And then if there are population norms, you'd maybe want to compare to those. But then it's all those other things. It's after your strength testing, it's the jump testing, and it's jumping in different planes. So vertical jump testing, horizontal jump testing in the sagittal plane, in the frontal plane. And then you did out on there adding video when appropriate to try to look at the kinematics and just make sure that the strategies that they're using to complete the jumps are safe and they are similar to what you're seeing on the uninvolved side. So I think if we add all those things together, you can really justify returning to sport. You're kind of leaving as few guesses on the table as possible. You're kind of proving to the patient, and the patient's proving to themselves along the way that I think I can return. Like, I'm nailing all these things. There's no reason for me to not feel ready to return. And then probably maybe some form of psychological readiness questionnaire or something like that we see in other joints. So I think all that's great. And if we all do that as a profession, I think we're really elevating our return to sport guidance, which is pretty cool.
Yeah, and it's a pain in the butt, right? It's not always like we see patients 1 or 2 times a week, every week. Like oftentimes people are getting hurt in the middle of a sports season. They don't come that frequently. They leave prematurely. You have a time to strength. It happens all the time, right? But I think when appropriate, wherever you can, we probably should be doing some form of strength testing. Do it as best you can. This is messy, right? For a lot of folks, they don't go through rehab in the way that we would often like. But when appropriate, when you can, I think getting some of these tests done is going to be helpful for patients. Or at least if they do decide to return without being tested, just let them know there might be some risk. You may end up with some recurrence potentially, right? But again, we don't know this, so we're just guessing. You might be telling someone they're going to have recurrence when future research shows that they don't, right? Who knows? Step number 5, physician referral. This looks like a very nice fake physician that was auto-generated by ChatGPT here, but he looks so real, right? Looks so good. Sorry if you guys listen to this. We use a lot of AI generated images recently, and this is a good one. I like this one. So essentially, if your patient is making no improvement or symptoms are worsening, we probably want to refer back to the physician somewhere between 4 and 8 weeks. One of the things I will say is that one pathology that has been studied, FAI and hip labral pathology, usually you're trying to rehab for 3 months before you refer back. So my first thought from these expert recommendations was that might be a little bit premature, right? We may be able to extend that a little bit longer, but the problem with FAI is if you let it go long enough, so more than 3 months, then the surgical outcome's usually a little bit worse. So I think this is absolutely fair. If you're making zero progress or worsening within 4 to 8, probably want to send it back. If you're making some progress, probably want to keep them around until about 3 months. And at that point, you kind of make a judgment call of like, is this person getting better? Do we just keep on going? Or should I send them back to the doc because they're really not getting back to the activities they want to get back to, right? And the second piece that the experts talked about was severe dysplasia. And this is diagnosed via lateral center edge angle. If you don't know how that's calculated, check out our series on what patients need to, or physical therapists need to know about hip dysplasia. We talk about the lateral center edge angle in depth. But if your lateral center edge angle is less than 20, that's categorized as severe dysplasia. And it may require faster referral back to a physician, although we have no idea if that's true or not, right? So this person has a lot of dysplasia, not getting better, potentially get worse. Maybe we send them back a little bit sooner. If they have borderline dysplasia, progressing very slowly, but making positive changes, then maybe we wait a little bit longer, maybe closer to 8 weeks or even 12 weeks to refer back to the surgeon, right? And always, when in doubt, refer out, as long as you have good surgeons, right? And that's an important caveat because sometimes you send to a bad surgeon, they get bad advice. But when in doubt, refer out to good surgeons who can take a second look at that, help you out. What I will say is that I'm happy that we have good local hip surgeons because hip dysplasia is not something that most clinicians treat a lot. And there are specialists that all they see is hip dysplasia. So they've got a ton of reps. So they're going to have a better idea of what is potentially going on with your patient. As long as you trust them, they're good specialists, then obviously it's a good fit, right? Any thoughts there, Kevin?
Yeah, I think that's a good conversation to even have day one with the patient. It's just, we have this plan for rehabbing this thing over the course of the next, 1 to 2 months. We definitely should start noticing some improvement. But if we're not getting where we need to be, we have this great surgeon, or, you have to say surgeon, great orthopedic doctor we could refer you to just to get a little more information about what we think is going on and why it's not responding to rehab. And then I think the patient likes knowing that they're not going to be just in almost like rehab purgatory. Like there is a plan. If I'm not getting better, there's a next step. And I think having that next step in mind is helpful just in case things aren't going well. They're not a little worried that there's no solution here. I mean, we could send you to an orthopedic and figure out why things aren't getting better. Like you said, is it actually some anatomical reason where this might need surgical intervention sooner? That's a good conversation to have early on. And I think for some things that we're fairly certain would benefit from surgery if PT fails, it's just good to talk about that with the patient right away. They kind of have a better idea of what the future looks like if things are not going well.
And if you guys want to get some CEUs for physical therapists, physical therapy assistants, and athletic trainers, I would consider subscribing to Fitness Pain Free Insiders Academy. We'll put a link in the description where you can get CEUs for listening to this exact content. If you want to learn more about exactly how we treat these patients, inside of Insiders, there's a master course on hip dysplasia, and we have a case study to see exactly how we go through rehab. And on top of that, we have a protocol. It tells you exactly what to do. Week 1, week 2, all the way up to week 12. So if you're interested, there's a $1 trial. It's $25 per month after that. I'll put a link in the description so you can check it out. And if you want to keep on learning, you probably want to make sure that you know how to diagnose hip dysplasia. Well, we have a 100% free video for you. It's going to be living right over Kevin's head. And in that video, we go over how to diagnose hip dysplasia to make sure you have the right pathology that you're treating. So click on that video and we'll see you there.